and good morning to Chris both. Uh, Today we are going to talk about financial toxicity and time toxicity, and we can see how it happens in the south as well as north of the globe. And uh, we have Dr. Christopher Booth as well as Dr. Aju Mathew. So, uh, Christopher Booth is a medical oncologist and he's a health service researcher at Queen's University, Canada. And he's also a professor of oncology and public health science and holds Canada Research Chair in Population Cancer Care. And he's the director of Division of Cancer Care and Epidemiology at Queen's Cancer Research Institute. And he is actually a good friend of Pilim India, helping us in many ways. And from his profile, you can see he is doing a lot of research. But importantly, in 2016, Dr. Chris Booth spent a sabbatical as a visiting scientist at the Regional Cancer Center, Trivandrum, in India. He's an advisor to National Cancer Grid of India, NCG, and most of you know that. And then honorary consultant at Pilim India, and a member of WHO Essential Medicine List Cancer Working Group. And he has a lot of publication in peer-reviewed journals. And he is acting as a research supervisor for many trainings. And in 2022, he received the Exceptional Healer Award at Kingston Health Sciences Center. So welcome, Chris. And next is Dr. Aju Mathew. So Aju Mathew is a American board certified medical oncologist and hematologist, and an attending physician. And he's working as a consultant in MISC Medical College, Collingery. And when he was working abroad, he was the co-director of Hematology or Oncology Fellowship Training Program. And he is also an adjunct faculty at the Kasturba Medical College, Manipal. Then he did his MBBS from Government Medical College, Trivandrum. And then he got trained in epidemiology from Cambridge University. Then molecular biology from Karolinska Institute in Sweden. And residency in internal medicine and fellowship in hematology for medical oncology from University of Pittsburgh. And he is also closely associated with Pilim India, and he is a board member of Pilim India Inc. So welcome, Dr. Aju Mathew. And now I would invite Dr. Chris Booth to deliver his talk.
Sir,
Actually, I will start. I think Chris hasn't joined yet.
Okay. Yes. Yeah. Okay.
So I'll start. And thank you, dear Dr. Sunil, for this opportunity to talk to all of you. Dr. Sunil has been discussing about this course for some time with me, and this is an excellent opportunity to get deep into the field, get a very good understanding. And it actually is very thrilling to see my picture next against Chris Booth's picture, because he's a legend. And, when you yourself put yourself in the same pedestal as a legend, you get goosebumps. So that's what I have now. Anyway, without much delay, let me actually start. Okay, it's in the slideshow mode, right? Everybody can see that in the slideshow mode. Okay.
Yes.
So over the next half an hour, I'm going to rush through some slides because I want to give Chris the maximum time to talk. But I'm always available to answer questions. So if there are specific points that you want me to revisit, please, during our question and answer session, I'd be happy to do that. Over the next half an hour, I'll talk to you about financial toxicity in cancer care, as it pertains to where I practice now. Earlier, I used to practice in North America, so I'm familiar with the way cancer care is practiced there and what happens there as well. So I have a broad understanding from two viewpoints, from the Western viewpoint as well as from a Southern, or rather an Indian viewpoint. But to start with, let me first define this terminology, and to help all of you understand the why we call it toxicity, financial toxicity. This is a manuscript that was published in one of our key journals. What this showed was there is a factor in this group of patients which helps separate out patients into different survival outcomes. So for instance, the patient with the blue line does much better than the patients in the red line that you see there. The patient in the orange line did middle. So with regards to all of them had cancer, and all of them had different outcomes. Some did well, some did poorly. But you can separate out who did well, who did poorly based on an X factor. And that X factor is what we call redlining. Redlining is a way in which certain localities are marked by mortgage lenders as bad areas to give mortgage to. So when investigators check to see what are the outcomes of patients with breast cancer who live in the red-lined area, they found that they did very poorly. That is, those who lived in areas or localities where they have difficulty in getting loans, mortgage lending buyers, that is, they're poorer, did poorly. But their cancer is the same, their disease is the same, then why do they do poorly? That's why this financial toxicity is a big issue. Now, if you look at it one way, cancer outcomes directly associate themselves with financial toxicity. Financial toxicity impacts cancer outcomes as well, as you've just seen. So therefore, financial toxicity in cancer care it's no more an elephant in the room. When there's an elephant in the room, we barely recognize that there's an elephant, right? But now people are more understanding that, increasingly understanding that this is something that you really have to talk about. So let me first define what financial toxicity is. Financial toxicity and financial distress are used to describe how out-of-pocket costs can cause financial problems for a patient. In the Western setting, when you have insurance, you pay for co-payment. So when you go to see a doctor, if the doctor charges $100, you may have to pay $5 and the rest 95 will go to the insurance. So that's called co-payment. Deductible is the amount that you start paying before which your insurance starts paying completely. So for instance, if you have an insurance company, you have $1,000 bill, you pay the first 200 and the rest, whatever the bill comes, the insurance pays. That's called deductible. Co-insurance is percentage of cost you pay for a service that your health insurance covers after you have paid your deductible. For instance, you pay 20% and your insurance pays 80%. So there are different ways insurance companies charge patients out-of-pocket expenditure. From the setting of an Indian context, everything is usually out-of-pocket. So financial toxicity is whatever financial burden a person or a household ends up in as a result of their cancer problem. Catastrophic health expenditure, or CHE, refers to any medical expenditure that can threaten the financial stability of a household. It results when healthcare costs are much higher than the patient's income. So what happens? When your income is low, but your healthcare spending is very high, then you sort of try to save on entertainment. You stop going to movies. You buy just the bare essential food. You don't buy clothing. You compromise on your shelter. You sell your house, and you just sell your house and just live in okay, and you just and you just live in a small household. So these are all ways through which people actually try to um, spend for their own health expenditure. So when your income and your spending is in disparity, you end up with catastrophic health expenditure. So there is a definition for that terminology. According to World Health Organization, any out-of-pocket medical expenditure in excess of a 40% of households' non-subsistence income, or it is health expenditure greater than 10% of monthly household income. So for instance, if my monthly household income is 10,000 rupees, but my health expenditure every month is 2,000 rupees, then I am going through catastrophic health expenditure, because I need money to live, I need money to eat, to stay, to pay my current bill and whatnot. So anything more than 10% of your monthly household income is considered catastrophic health expenditure. Now, how do patients meet this expense? Most often, they meet it through distress financing. It's something we all know. People pawn their jewelry or sell their assets. So that's called distress financing. In India, when we reviewed 22 studies from India, we found that nearly 54% of patients with cancer experienced catastrophic health expenditure. It's a big number. So, what is the impact of financial toxicity of cancer care in India? Um, there's a high out of pocket spending because of poor health insurance coverage. And why does this happen? Because our government spends very little on public health spending. But more importantly, it happens because a lot of our cancers are diagnosed at an advanced stage. Because you have financial toxicity, people may forego care. They have poor quality of life. They delay therapy. They lack follow up. They don't adhere to therapy. A lot of my patients don't take medicines as prescribed. They don't come on follow up as prescribed because they just can't come because it's too expensive for them to come. So these are the consequences on cancer care. So if you're not taking therapy as advised, you end up with poor outcomes. So the impact on family, you end up with decreased expenditure on education and entertainment. A lot of my family members actually go to work sooner than they should. Young men, they have to stop their college education because they now have to work to bring food home. The accumulation of debts leading to long-term hardship. They may have to do overtime work, part-time jobs. So even the family gets substantially impacted. Catastrophic health expenditure is not an India only problem. It's generally a problem of the southern hemisphere or the less developed regions of the world where there is poor public health coverage. So as time has gone by, cancer outcomes have improved. As we can see, a lot of the cancer survival rate has dramatically improved. Several years ago, 25 years ago, breast cancer, only 75% of patients used to live at 5 years, but now it's around 90%. But this improvement in outcome is coming at a cost of substantial health expenditure in the part of government. The United States spends nearly 1 in 5 of whatever they produce on healthcare. India spends around 1.5% on healthcare. That's very poor. United States 1 in 5 number is very high. That's not sustainable. But the sweet spot is something like 3 to 5%. We are not there yet. We've been always telling the government, pleading with them to increase the budgetary spending on healthcare, but it never happens. Now, why is this getting increasing attention? That is because as time goes by, the health expenditure is going to really increase. The spending on cancer care is going to see huge increase from $182 billion, this is US data in 2015, to $200 billion in 5 years, to $245 billion in about 15 years. Pretty big increase. So there is a problem that urgently needs a solution. Now let's talk about what are the solutions that can potentially help mitigate financial toxicity. Now I'll just give you broad brush strokes at the level of patient, at the level of the doctor, at the level of the community, and policy level. At the level of patients, it is very important to obtain accurate information on the disease and treatment options. A lot of the patients, when they come to you, when they come to me, do not ask me, what is the stage that I am in now? So get accurate information, get a second opinion. Tell your doctor how much money you got, because the doctor needs to know. I don't know how much money you've got. There may be a drug, maybe something called bevacizumab, which actually costs 20,000 rupees per month. It may help you live another 6 more months. But 20,000 rupees a month for 6 months is 1 year's worth of your income. Then is that 6 months of extra life worth it? So these are the sort of questions that you got to ask your doctor. Discuss and document advanced care directives for end of life. A lot of the health expenditure happens towards the end of life because patients don't talk to doctors, patients don't think about their own wish for end of life care, don't communicate to their relatives. If that is stated very clearly, we would put far fewer patients in ICU, we would put far fewer patients on ventilator. We can save a lot of people from unnecessary health expenditure. Enroll in government schemes, discuss cost of care with the doctor. Now, I'll give you an example. Discuss cost of care with the doctor. In the US context, in the Western context, Chris will talk about it, but I'm going to also share my thoughts. If you go ask the doctor in the US, I'm worried about how much cancer treatment is going to cost me. Can we talk about it? The fact is, none of the doctors in the US really knows how much a certain medicine is going to cost, because the healthcare system over there is so much in shambles that nobody knows how much a drug is going to cost until you complete the therapy and you get the bill in hand. But that's not the system in India. In India, I know precisely how much certain things do cost. An example is from a big hospital in the United States called Johns Hopkins University. In the Johns Hopkins University, researchers randomly assigned some diagnostic test to an active arm. The active arm, fees or the charges of the test were displayed. In the control arm, charges were not displayed. So what happened? When the doctor knew that a test for potassium cost $20, then they stopped ordering it every day. I am guilty as charged, by the way. When I did my residency in the US, I used to order electrolytes every single day for all patients who were admitted under my care. Daily sodium, potassium. Now, when patients are admitted under my care here in India, I rarely order it because now I know how much it costs. So what this experiment in the US showed was, if you actually tell doctors how much tests cost, chances are they would order fewer tests. And that's what happened. Price transparency is important. A lot of the hospitals do not display how much certain things cost. We need to be upfront with patients. Okay, you go for a colonoscopy, this is going to cost this amount. Or you go for a colectomy, removal of the colon, it's going to cost this amount. So you got to be having price transparency. At the level of provider, at the level of the doctor, I have to screen patients for financial toxicity. To conduct cost discussion during clinical encounter in a more proactive way. I must be open enough to allow patients the freedom to discuss, their thoughts, their confusions, their problems. And I must be judicious when I order diagnostic tests, and I must adhere to guidelines. I should be careful to avoid low value care. There are several therapy out there that will probably help make you live maybe 1 month, 2 months extra. You may be laughing, my dear friends, but as oncologists, we adopt it as our standard of care. If you look at our guidelines, the guidelines would say patient with this disease, give that drug. But if you dig deeper into the guidelines, you would see that using that drug will probably help you live maybe 2 months extra. So that's why you should actually understand the rationale for guidelines, understand what is high value care and what is low value care, and discuss that with patients. Good quality surgical care is very important. Good quality radiation treatment protocols are important. And early palliative care for patients with incurable cancer is very important. This has been shown in multiple studies. So if I have This is more relevant in a Western context where this never happens. In an Indian context, most doctors actually talk about palliative care, but a lot of us do not have the resources or the means to find a palliative care specialist for referral. But even if I have resources, I'm extensively connected with palliative care professionals. Even in spite of that, I'm having a hard time referring patients with incurable cancer to palliative care professionals early itself because of the stigma associated with palliative care. That is the challenge here. Morphine. Imagine when I have to prescribe morphine to patients who are in pain, even patients who are not dying, they wouldn't take it because the word morphine is associated with death. So it's a challenge for doctors to actually talk to patients and convince them and to take certain medicines to do the right things for them. So cost discussion is important. I'll just skip through this. Judicious use of diagnostic tests. We know there's a lot of wastage of health expenditure happening because of unnecessary testing, unnecessary duplication of tests. Even now, if I have a patient who have done good quality pathology tests, I refer this patient to RCC in Trivandrum, they would repeat everything. Why? I don't know, but they would repeat everything. And not always does the government pay for it. Now, even if the government pays for it, still it's an expenditure. Somebody is paying for it. Do they really have to repeat all these tests again, even if it is done at a very good quality lab? That's up for debate. Choose wisely. We have a lot of campaigns going on to educate doctors to choose wisely. I'll give you an example. Patients with bone metastasis, for palliation, you could give radiation to that bone site. You could give it in 10 fractions, that is over 10 days. You could give it in 5 fractions, or you could give a single dose. Now, studies have shown that a single dose is sufficient, would give the appropriate amount of pain control as would be obtained through 10 days of radiation. But one dose of radiation is cost effective because the patient doesn't have to travel that many times. Patient doesn't have to stay in the hospital those many days. But still, even then, we now give 10 days of radiation for bone metastasis. So choose wisely. Avoid low value care. Now, this is from Chris Booth's paper, where he actually talked to his patient about a drug that we use in colon cancer. He said, there is a drug that is commonly used in colon cancer. It will not make you feel sick, but it is associated with some rare, serious side effects. But this drug slows down the growth of cancer on a scan by 1 to 2 months, but it hasn't been shown to help you live longer. Would you like to take that drug? And the patient bewilderingly looked at Chris and said, why would anyone take that drug? But yet, this drug is one of the blockbuster drugs. It's right at the top of this chart, the biggest selling product actually in medical history. So despite the fact that it is not a very, very powerful drug, we use it left and right now. I use it regularly in my practice. In certain situations, maybe a little more often than I should, but it is based on how much the patient can afford, unfortunately. Just blind adherence to guidelines. The guidelines would say use it for every single patient that walks into your clinic with colon cancer, but you have to be prudent, you have to be wise, you have to have that kind of discussion like what Chris just had with the patient. Early palliative care, early end-of-life discussion is associated with less aggressive care and greater use of hospice at end-of-life care. And that's how you save money. Because I just mentioned that a bulk of our expenditure happens towards the end of life. So if you can save that money when you know that it's going to be wasted, how do you do that? Either a doctor talks to your patient and says, hey, be prepared. Things are going to be rough. Would you want to prepare your advanced directives? Or at least if you're not in the mood to do that, refer to experts who can do that. That's early palliative care. So essentially a cancer doctor is a gatekeeper for the patient. A cancer doctor has to advocate for the patient, have to choose wisely, have to refer appropriately, have to discuss goals of care appropriately, sometimes even have to obtain financial assistance offer payment options. Now, this is something that I regularly do. Today, while I was in clinic, one of my old patients came to me and said, Doc, I have some money. I want to give it to a patient. I asked, how much is it? 50,000 rupees. I said, come right away, come over. Just the patient prior to that was just getting admitted for curable cancer complication. I took her to that patient. They handled it over themselves. And the patient was so relieved. Sometimes this is what I do for, during my clinic practice. You know, I network, I find money for patients' care. I called people up, I call my friends, I say, okay, I need a patient, I need money for a patient, would you be willing to support? So oncologists, unfortunately, especially practicing in India, have to do a lot of these things, have to be a gatekeeper for the patient. At the community level, we have to conduct awareness on cancer prevention, because bulk of the cancer expenditure happens because the diagnosis is late. So how can we shift the diagnosis from late stage to early stage? Information, awareness, empowerment. So you got to find philanthropic support, cost-sensitive lodging facilities. One big challenge in India is unconventional alternative medicine clinics. You would see a lot of frauds and quacks and crooks here. I was just going through my pictures yesterday and just happened to see a picture from a patient with fungating breast mass who I treated, and she said she had gone to see a guy in Wayanad. I had taken a picture of the bill, monthly bill, 10,000 rupees for what is it? It's just leaves, water, you know, that you can just pluck off plants in front of your garden, you know. So our people are gullible. Patients with cancer are gullible. Yeah, but that's where our community does a bad job in regulating these efforts. Some of the most viral messages on Facebook are produced by these quacks. So for instance, if you're a Malayali, you may have seen a video from a guy named some Vaidya. It was so viral. Millions had watched it. I myself got it from more than 10 people as a WhatsApp forward. When you look at the number of people who have shared it, it runs into thousands. As a response to the fraudulent message, my patients were starting to think about going to him. I created a video and I put it on Facebook. The number of people who watched this is probably 1,000 or 2,000, as opposed to millions. The number of shares I got was probably 50, as opposed to thousands. So truth rarely sells, and we are gullible, we are culpable for all of that. So we got to use social media judiciously. At the policy level, we have to increase health spending in cancer care in the public health sector. We have to help enroll eligible persons in government schemes. We have to include cost of care discussion in training programs. Right now, what we are doing is that we are having such a discussion in training programs. Cost-sensitive drug approval, introducing high-quality generic research, and development of indigenous research. Preventive strategy, anti-tobacco measures, strengthen population-based cancer registry, encourage clinical research, encourage insurance acceptance, incorporate health technology assessment programs, discounted lodging. A lot of these things can be done for patients. One such policy proposal is to include list of essential medicines. What is actually absolutely essential to improve the lives of patients. And recently, Chris's team studied whether drugs were universally accessible. Universally accessible implies a drug is available for more than 90% of patients with no out-of-pocket expenditure. If oncologists were asked whether immunotherapy was universally accessible, more than 2/3 of oncologists said it is universally accessible, which is not right. It is not universally accessible in the US. Patients have to pay substantial out-of-pocket expenditure even now for getting immunotherapy, but doctors think it is universally accessible. So just getting medicines on essential medicine list is not sufficient. Getting the right medicines, there is a debate, should we have cost of care put into the equation of whether a medicine is chosen to be part of an essential medicine list? Some say yes, we should. Some say we shouldn't. You know, we can ask Chris. He should be joining us shortly. So there are several ways we can do this. And the other, the way you can actually build this sort of discussion is by talking about value. Chris may talk about it, so I'm going to just skip through this part. Basically, value is what you, the benefit that you may get based on how much money you spend. You may spend a lot of money, but if the benefit is low, then that's a low value therapy. Just like diamond, you pay a lot of money for a diamond. You pay very little for water, but you die without water. You won't die if you don't have a diamond. So what is valuable here? Is it the diamond or the water? What is valuable? I think value is what you get, and that water is definitely most valuable. I think this comes from Adam Smith, the famous economist, 18th century economist book. So value-based healthcare is being increasingly debated now. So there are various scales that societies have adopted to figure out certain intervention have high value or not. One such scale is called the European Society of Medical Oncology Magnitude of Clinical Benefit Scale. So for that same drug called pertuzumab, if used in metastatic setting, it may be valuable. If used in an early stage setting, it is not valuable. So then based on such information, the insurance company or the government can decide to either pay for that therapy or not pay for that therapy. At least you know whether that drug is valuable or not. There are a lot of policy measures you can do to actually bring medicine into an affordable range. One is called compulsory licensing. You can actually license a drug despite the fact that it is still within the patent protection. If the government feels that compulsorily licensing that drug to be manufactured locally in the country is important for public health benefit. Till date, only one drug has had that privilege for compulsory licensing. I think it's insufficient. We should have more compulsory licensing. But the problem is, the question here is, if we start licensing drugs compulsorily, are we infringing on the intellectual property too much? Are we curtailing innovation, innovative research? It's a debate that is yet to find the right answer. Generic drugs, having generic drugs are widely important. Having biosimilars, these are copies of original innovators. A lot of the drugs that we consume in India are generics, and that's how the costs have been cut down. But the problem is drug quality check. How can we ensure that the generics that we use in India are of good quality? That's where the government has to step in. A new field to try to figure out whether actually it helps to play around with the doses of medicine or frequency of medicine is called pharmacoeconomics. It's called interventional pharmacoeconomics. I'll give you an example. Abiraterone is a drug that we use for prostate cancer. The actual dose of the drug is 1000 milligrams given in a fasting stage here. But at the same time, studies have shown that if you give 1/4 of the drug along with low-fat meal, you would get approximately the same amount of medicine within your bloodstream as you would get if you take the full dose at a fasting stage. So for a lot of patients, my patients, I give 1/4 of the dose, but I just time it with their food intake so that I save their money. I get almost equal effect as well. So that's called pharmacoeconomics. So I'm going to summarize here and I'll let Chris take over from here. But what I've been trying to tell you is that among all sorts of toxicities we talk about in cancer care, financial toxicity is no more an elephant in the room. It is something that is ready for discussion, something we got to talk about. And the consequences of financial toxicity is at various levels, at the cancer outcomes level, at the family level, at various levels, at the patient level, at the society level. It directly impacts cancer-related outcomes. If the patient cannot afford a therapy, they would forfeit that therapy, and cancer recurs, and that impacts their outcomes. Can wreck a family by causing catastrophic health expenditure. There are ways we can mitigate the impact of financial toxicity at the patient level, at the provider level, at the community level, and at the policy level. So I'll stop here and I'll see if you have questions, maybe now or later based on what Dr. Sunil suggests.
Yeah, we can have it after both. group's presentation. So Pressbook.
Hi,
We
Sunil.
can-
Do you want me to
yeah,
should I lecture now and then we'll have questions after, or questions first?
yeah. First your lecture and then questions after that.
Okay, great. Let me just
I
take
have
this.
already introduced you, so you can straight away go and have your
Great. Great, thanks everyone. Aju, that was a great lecture. In fact, I've seen many lectures on financial toxicity. That's probably the best one I've ever seen. So the fellows have been in for a real treat. So I'm going to try to follow that and actually build on many of the concepts. Aju and I, we look different, but we're kind of brothers in the sense that we share many of the same worldviews. And so you're going to hear some familiar themes in my talk, which will build on many of the concepts introduced so well by Aju. I'm just going to go ahead and share my slides. All right, can you see the slides okay? Just give me thumbs up.
Yeah.
Yeah, great. Okay, good. So I'm going to touch on what I call the value crisis in cancer, which one of the consequences, or one of the clinical symptoms of the value crisis is financial toxicity, which Aju has reviewed. And this has relevance in all health systems, particularly in the Indian context, where there's very limited, public services for some patients and some populations. But this is an issue that affects all of our health systems. And then within value, we'll talk about another form of toxicity we've been thinking about lately called time toxicity. So this is going to be provocative. There's not many oncologists in the world who will say these things publicly. Aju is one of them, but we're starting to change. And I think the palliative care doctors and nurses have been waiting for decades for the oncologists to wake up and talk about many of these problems that we're now kind of hopefully making some strides in. I have no relationships with the pharmaceutical industry, which is great because I can say anything I want and they can't do anything about it. So if you take a step back, as clinicians, as practitioners, and globally minded oncologists, what do we actually care about? And I think these are some of the themes that really get to the core of what it is we want to do in medicine and public health. We care about issues related to access, equity, health justice, affordability, quality, outcomes, and patient-centeredness. And I think it's a bit of a shame within our field in oncology that instead of seeing these words over and over again, we see words like game changer, precision oncology, breakthrough, life-changing, and we've kind of lost sight of what it is that really matters. And I think the palliative care community, again, has been advocates for these issues for a long time, but we need to make sure that that voice gets louder and that community speaks up more and more. Because if we don't, we risk problems, many of which Aju's just outlined in his previous lecture. So the cancer value crisis, and I know that palliative care is more than oncology, but a large part of what you're going to do as palliative care doctors is looking after patients with cancer. But in fact, I think the issues of financial toxicity, of value crisis, and time toxicity applies across all of biomedicine. There is a crisis of value in many things that we do. Probably the only area that does not have a crisis in value is palliative care, but anyhow, we can talk about that later. So in oncology, we have three big problems. We have dubious endpoints, we have small benefits or effect size, and we have the staggering price of cancer care. So let's unpack that a bit. Aju and I are not economists, and so we think about value as very simple medical oncologists. And that is exactly as he said, which is the intersection between what you get, what's the magnitude of benefit, and what you give up, so the costs. And so whenever I review a clinical trial, or I'm in my outpatient clinic with a fellow, or at the bedside with a patient, and I'm thinking about a new therapy, and I reflect on the clinical trial, I ask myself three questions. Number one is, what is the endpoint that was proven to be improved in the clinical trial? Question number two is, what is the effect size? That means, how large was the benefit? And question number three is, do both of these things matter to patients? If the answer is no to any of those questions, then we really should not be giving this treatment. And as you'll see, we have big problems in all of these issues. Before I get into the concept of magnitude of benefit, I'm going to speak very briefly about what I call the denominator, which is the cost or the price of cancer treatments or largely cancer medicines. I'm going to speak about it very briefly for two reasons. The first is that lots of people have written about this. I think we all acknowledge the price of cancer medicines is completely inappropriate. We need to speak out about that. We need to work on policy solutions, and we need to make sure that everyone knows about this injustice. But the reality is, as oncologists or palliative care doctors, individually, we don't have very much control over the price of cancer medicine. It's a little bit beyond our reach. However, where we have total control is in the numerator. We are the doctors that design clinical trials. We are the people that write guidelines. We are the people that make recommendations to government schemes for funding, and we are the ones at the bedside that make recommendations to patients. We own the numerator, but we've abdicated that responsibility because we blindly follow guidelines, which are often driven largely by pharmaceutical company interests. And so we need to take back the power of the numerator and have more honest conversations about whether our treatments actually help patients. Because if we're giving treatments that don't help patients, there's a whole cascade of bad things that happen, one of which is financial toxicity, as we've just heard. So let's briefly look at the issue in the denominator, the price of cancer care. So this slide's now a few years old, but what it shows is that over time, there's been a skyrocketing increase in the cost of cancer medicines. In North America and many parts of Europe, we now live in an era where the typical cancer medicine costs about $200,000 per year. And even as Canadians, we often look to the FDA in the United States as being a completely crazy cancer and healthcare system. And it largely is a crazy system. And in some ways, it doesn't apply to the rest of the world, but it has a huge knockoff effect. And that's because if the company can price a medicine for $300,000 a year in the US, even though they know that Canadians and the Brits and the Norwegians and the Indians and the Sri Lankans will not pay $300,000, it raises the ceiling so high that then they still charge $180,000 in Norway and Canada and $60,000 in India. So what happens in the US actually has a huge knockoff effect for the rest of the world. So the prices are completely out of control. The other problem, and this is from our group, is that unlike any other economic model, there is no relationship between how well the medicine works and its price. So this is completely counter to anything that we know about. If you want to have a nicer car, you spend more money, you get a faster car. If Aju wants to have a very fancy skateboard that makes him look like he knows how to skateboard, he'll spend more money and get a good skateboard that's better skateboard. It might not help him make more tricks, but there's usually a relationship between how much we spend and what we get. In cancer medicine, we found that not only is there no relationship, if anything, there's an inverse association whereby the drugs with the smallest benefit have the largest price. And so you don't need to be an economist to know that's a completely broken economic model. So that's really all I want to say about the price of cancer medicines. We've gone over some of the consequences of financial toxicity in the previous lecture. And I don't want to minimize the impact of these prices. We need to advocate very strongly. And Aju's been a leader in this space, both within the Indian system and globally. And a number of us work with the World Health Organization Essential Medicine List to try to have a rational conversation about this. But now I want to shift to the numerator, which is some of the concepts about endpoints, magnitude of benefit, and then we're going to get to time toxicity towards the end of this talk. Progression-free survival. This is an essay I wrote now over a decade ago with one of my mentors and colleagues here at Queen's, Dr. Elizabeth Eisenhower. And 10 years ago, we asked the question, is progression-free survival meaningful or simply measurable? And this was really in the early years where PFS was becoming, a dominant endpoint in our field. And in some ways, it makes me very sad that here we are 10 years later, and we're no further ahead. If anything, PFS has become entrenched. It's now the king of oncology. And I think the question now is, it might not be meaningful. And in fact, we're learning more and more that PFS probably isn't even very measurable. And that's because there are a number of forms of bias that limit whether we can believe differences in progression-free survival. Let's unpack that a little bit. Okay, so I think the only two oncology nerds on this lecture are Aju and myself. So the rest of you, fortunately, probably don't know too much about tumor measurements, but this is an oncology problem we've created. So progression-free survival is a composite endpoint that includes survival. So if the patient lives or dies, that's an event. But most of the events in this composite endpoint relate to whether the tumor grows. And so it's defined as 20% increase in the size of a tumor or the development of a new tumor. And this drives everything when it comes to clinical trials, regulatory approval, and what we do in practice. Progression was invented for phase 1 trials to help oncology drug developers get an idea of, is there activity, yes or no? It was never invented to be used to guide phase 3 trials or clinical practice, yet here we are. And so just to illustrate this, so this is your baseline tumor. Imagine this is a tumor of 2 centimeters in your lung of a healthy, normal sized adult person. If it grows to that big, from 2 to 2.5 centimeters, it would be called tumor progression. Or if you have a new 1 centimeter tumor in your liver. Now, it's pretty obvious that whether the tumor grows from 2 to 2.5 centimeter probably has no bearing on how well the patient feels or quality of life. And it probably has no bearing on how long they're going to live. Right? Those are the two endpoints that should matter in all of what we do. That's what matters to patients: overall survival, how long they live, and quality of life, how they feel. Whether or not these changes occur probably have no relationship to either of those two things. So this is a paper we published last year showing over time, over 40 years of oncology trials, you can see in the early years, overall survival was the primary endpoint. It's easy to measure, and it's clearly something that matters to patients. But you can see over the last 20 years, overall survival is becoming increasingly less common, and progression-free survival now is the primary endpoint of almost half of medical oncology RCTs. The other thing that's happened, look at this. We now live in an era where more than 90% of clinical trials in oncology are funded by the pharmaceutical industry. This is another talk entirely on its own, but there's a lot of problems that come with that. Now, some of our very best clinical trials and therapeutic advances come from trials done in partnership with pharma. So I'm not saying it should be 0%, but it shouldn't be 92%. They now control the research agenda rather than being partners in the research agenda. So PFS in cancer, I'm going to give you, this is kind of the summary of, about a decade of thinking about this. Where can we use progression-free survival? Well, progression-free survival may be useful if it is a surrogate for something that matters to patients, really overall survival or quality of life. There are a number of statistical tests and principles that need to be met in order to define surrogacy. And what we've seen is there are a number of circumstances where PFS is a very useful and valid surrogate for overall survival. And it's totally appropriate to use it there. But what we found is in most settings, it's not a valid surrogate for overall survival. It's also not the case for quality of life. However, even if we ignore point number one, progression-free survival may be useful if it intrinsically matters to patients. Okay, if tumor growth matters to patients independent of surrogacy. However, emerging work from our group and others suggests this is far from certain. Patients might not actually care if their tumor grows from 2 to 2.5 centimeters, especially when one considers the clinical side effects, financial toxicity, and time toxicity that comes with that treatment, especially if it's not going to help them live any longer or feel better. And finally, even if either number one or number two is true, it's increasingly clear that at least some proportion of the apparent improvement in PFS may be due to artifact, and that's because of measurement error and something called informative censoring, which is the fact that when patients drop out of clinical trials, there can be artifact introduced into the data set that makes it look like there's a difference in progression-free survival when there really is nothing. So that's a little bit of warning about the endpoints of where we are in oncology. Now I want to shift to the effect size, 3 months. So this is an important number because it comes up recurrently in a number of studies that have looked at the average benefit of a new cancer medicine. So I want to take a step back and make a few statements. The first is that most new cancer medicines that are approved by the FDA, the EMA, that are included in guidelines that we use in practice every day. Most new cancer medicines do not improve overall survival or quality of life. I think we should let that sink in. That is shocking in itself. And I think the public and patients would be shocked if they heard that. Most of our medicines do not help people live longer or feel better. However, amongst those that do, okay, there's a substantial minority that do, the average improvement in survival is 3 months. Now, that's an aggregate, okay? Clearly in the last 10 years, we've had some explosive and transformative medicines in cancer that have made a huge difference. Immunotherapy for melanoma, imatinib for CML. There's been a number of drugs that have made a big difference, okay? But those are exceptions floating in a sea of mediocrity. Most of the drugs are pretty mediocre. They improve survival by 2 or 3 months. Now, I don't want to come across as uncaring, and I don't want to propose that 3 months doesn't have value for someone near the end of life. But we have to remember that those 3 months come with caveats. There is important clinical side effects and toxicity. There is very significant financial toxicity for the patient, the family, and the health system, as Aju has just described. There is this emerging concept of time toxicity we're going to talk about. And there's the idea that, you know what, it's 3 months in a clinical trial. It's almost certainly much less in the real world. That relates to the concept of the gap between efficacy and effectiveness. We'll get to that in a moment. So time toxicity, this is something that I think most clinicians, especially palliative care doctors, have probably recognized for decades. Oncologists, we don't talk about this a lot, but I think we recognize it too. Aju and I and our colleagues, not infrequently, we'll get a sick feeling in our stomach in clinic when a patient comes and says, "Hi, doctor, I came to clinic today. I skipped my cousin's wedding because I did not want to delay my cycle of chemotherapy." This happens to us not infrequently. And it always would make Aju and I feel sick when we hear that, because first of all, we know that near the end of life, these family and life events are far more important than our treatment. And we also know our treatments probably have small benefits, and delaying it or skipping a cycle would have no negative consequence. But anyhow, we started writing about this about a year or two ago. And of all the things I've worked on in my career, this is probably the concept that has resonated with public and patients the most. In fact, it's really taken off kind of in the popular press and the media. And I'm going to paraphrase what we wrote in one of our first essays. Time spent pursuing cancer treatment in waiting rooms, emergency rooms, and chemotherapy units is time that cannot be spent fishing, traveling, or visiting with loved ones. This trade-off becomes most pressing near the end of life when time is short and many treatments offer small benefits. Clearly, if someone is going to live for 5 years, 10 years, or 20 years, or if a treatment has large benefits, then the amount of time they invest in pursuing medical care is probably a very small proportion and makes a lot of sense to invest that time in treatment. Where we have the greatest concern about time toxicity is in the last 6 or 12 months of life, when time is most precious because it's short, and also because our treatments tend to have very, very small benefits. So this is something, another essay we wrote with Arjun Gupta and Elizabeth Eisenhower, published last year in the Journal of Clinical Oncology, where we propose a metric of time toxicity for clinical trials called home days. The number of days a patient can spend at home versus the number of days they need to seek healthcare for their cancer treatment. So, oncologists don't often discuss this, but patients want to know where and how they will spend their time, especially in the last year of life when time is very precious. And we've done some modeling with published clinical trials, as well as kind of our own data in-house from cooperative trials groups here in Canada. And we've shown that for some of these cancer treatments that improve survival by maybe 4 weeks or 6 weeks or 8 weeks, every added day of life is offset or traded by an extra day in the hospital or in the chemotherapy daycare getting treatment. And so we think we need to start measuring this in clinical trials so that we have information so that oncologists can talk to patients about these important issues. So how and where a patient spends their time matters. We're not proposing that we have the answer about how patients should spend their time. It's not up to me to make that decision. But I think that oncologists, we have failed our patients because we have not generated that data through trials, and we do not share that data with them in the informed consent process, because we need to empower them to make decisions about how they want to spend their time, so they can choose treatments that are most in keeping with their values and preferences. And imagine, this is for treatments that actually might, they do improve survival by a couple of months. Imagine treatments that do not improve survival, yet you might be spending every Monday at the chemotherapy daycare getting an infusion when you could be spending time with your loved ones. People make fun of me from our first essay where we use fishing as an example of what someone might want to do. Fishing is a popular pastime in Canada, but you can imagine in India, maybe to be going for a walk or playing cricket or having chai with friends. But anyhow, there's lots of things that our patients would rather be doing than spending a day at the chemotherapy unit getting treated. So this introduces the idea of trade-offs. And so some of these trade-offs, I'm just going to give you an idea of some of the concepts where we've been working on. So these are most relevant near the end of life when time is short and treatments have small benefits. So patients make some trade-offs. In the last 6 months of life, if they choose to have chemotherapy, they're trading off, obviously, time toxicity. There's financial toxicity. There's a trade-off about an existential acceptance of death and the planning for end of life. There at the research level, there's trade-offs. We're doing large clinical trials chasing small benefits, and these are not helpful for anyone. They identify trivial gains. They use precious resources, most importantly, our patients. They prevent us from answering other important questions, and smaller trials are better for almost all of these things. There's health system trade-offs, how we allocate nursing resources, how we use chair time in the daycare unit, delayed of procedures, consultations. This kind of tension, which I'll talk about later, with we might add 6 additional weeks of life, but we can't provide holistic, compassionate care at home in the last 6 months of life. And then if you get to the really big picture level, oncologists get very uncomfortable when we talk about this, but there's societal trade-offs. How are we going to allocate resources for cancer care as opposed to palliative care, public health, education, environment, infrastructure, early childhood development? These conversations are difficult with no clear answers, but I think it's naive for us to believe that with an oncology that we live in a bubble and we can continue practice as usual. One of the concepts I mentioned earlier was this gap between efficacy, which is outcomes observed in clinical trials, and effectiveness, what we see in the real world. And as we all know, the patients that go in oncology clinical trials are the Olympians of cancer. They are younger, fitter, motivated, more affluent patients. They have less comorbidity, lower volume disease, and better performance status. In fact, patients in clinical trials look nothing like the patients that Aju sees every day in Kochi, that I see every day in Kingston, or our colleagues see elsewhere in Brazil, Argentina, or England. So it's not surprising that the outcomes observed in routine practice are inferior. So this means these small benefits that we've talked about from clinical trials are almost certainly much smaller in the real world. So just in closing, we've talked about some of the problems with low value care. So I see the value crisis. There's an epidemic of value in cancer care at 2 levels. Number one, we have an epidemic of overutilization of low value care that don't help patients and probably cause harm. At the same time, we have an epidemic of underutilization of the elements of cancer care, including palliative care, that make a big difference. So this is a study that Aju alluded to, and in fact, he was one of the editorialists in Lancet Oncology for this study, where we did a global survey to ask oncologists which medicines are the most important for their cancer care. And in the interest of time, I'm just going to skip ahead to the punchline. We had 1,000 oncologists from 80 countries, and we asked them which cancer medicines are most important to them. And the vast majority were old chemotherapy and hormone drugs we've been using for 20 or 30 years. And in fact, these drugs should cost really a few dollars per week. What we found, though, as Aju mentioned, is that in very few health systems are these universally available. In fact, most of these medicines would cause catastrophic financial toxicity for families in order to access them. So, for example, I've highlighted here doxorubicin, the workhorse chemotherapy drug we've been using for many decades. And it's been generic for many, many years. Only 1/3 of oncologists can give it universally to all patients. 1/3 of oncologists can give it with financial toxicity. And about a quarter of oncologists said they can only give it at the risk of catastrophic financial ruin for the patient and family. Look here for trastuzumab, an important medicine in breast cancer, which is now available as a biosimilar. Despite being available as a biosimilar, only 15% of oncologists can give this universally to all women with breast cancer, while 2/3 of oncologists said they can only give it with risk of catastrophic financial toxicity. So this is a big problem when we consider all the new medicines coming down the pipeline that are much more expensive and have much smaller benefits. So this gets to the idea of something that my friend and colleague Vishal Gawali and a number of us have been thinking about for years, which is how do we better balance moonshot cancer initiatives with ground shot? So moonshot initiatives are those high-tech, aspirational, expensive, big science initiatives that might change cancer care in 5, 10, or 20 years. And we need to keep doing that for the treatment of tomorrow, but we need to better balance it with ground shot initiatives, which is implementing the knowledge we already have, or ensuring that the treatments we already know work are available to all patients with cancer globally. And this includes access to opioids and access to high quality palliative care. So I'm going to close with something that I call the last 6 months of life paradox. And in my center here in Canada, and this applies to many other centers around the world, in the last 6 months of life, it's fairly easy for me to give a very expensive medicine to a patient. The government of Canada will pay for this medicine. This medicine probably will not help my patient live longer. It might shrink tumors on a CAT scan for a few months. Certainly it has side effects as well as time toxicity. However, for that very same patient who might live by themselves and be socially isolated, scared, and feel sick, it's almost impossible for me to mobilize enough nursing and home care supports to keep that patient comfortable at home with compassionate care, nursing care, and good food. And so we've got this terrible paradox where I can give an expensive, useless drug that causes harm, but I cannot ensure that the basic needs of that patient are being met. And so the oncology community really needs to do better. And I think that part of this conversation today is how can we do better, and raising awareness is one of the important ways to do that. So a number of us have been popularizing, working on this idea, we need a common sense revolution in oncology, and this will require changes in how we deliver care, how we teach the next generation, and the research and policy initiatives that we're involved with. Thanks again for the opportunity to share these ideas with you this morning and this evening in India. Happy to take any questions. And as you can see, Aju and I our work really intersects and we kind of see the world in many of the same ways. So look forward to the conversation we have now.
Thank you, Chris. So before moving on to the questions as such, we have an oncologist in this fellow group. So let us ask him to talk about what he thinks about this. Dr. Ravi Kiran, he's a radiation oncologist. Dr. Ravi Kiran?
Dr. Sunil, I don't think he heard it.
Dr. Ravi Kiran, are you there?
He's there and visible, sir. Yes.
Sir, yeah, but I couldn't hear you. Yeah.
Yeah, I was asking your opinion before opening it to our friends.
Sir, as an oncologist, I do practice chemotherapy as well initially before. So we were in a government setup where huge fancy drugs were not been available. So we have the limited capacity and the limited resources. And after the second line of therapy, we give the patients the options of best support to care as well as the third line, which work or may not work. But most of the patients do feel that choosing the best support rather than choosing best support to care, go for the third line, despite being counseled multiple times that it may not have much benefit or much fruitful for them, even for the survival. But the patient and the caregiver, so most of the time they choose to prefer to have a third line chemo, whatever resources which we have, rather than going with the best support. Okay, as in the corporate setup, most of the resistance does come from the oncologist by using the fancy or the newly trained or newly developed, which their orientation is little bit different when it's like they don't want to accept the defeat that we have now haven't get cured or haven't been treated. The orientation among the oncologists is a bit challenging. When I have come to the palliative care domain completely, this resistance does happen, and even the orientation at that point of time, the oncologist should also give the opinion or the advice, suggestion to choose among them. But the option of best supportive care will never be an option. You choose the fancy drugs or the low fancy drugs. That's what the options given to the patient and the caregivers. And at the end of the terminal care, the palliative care option, the supportive care was given. So in this way, the patient and the caregivers were also in a dilemma where and how and what to approach and which will be the fruitful. So I think even the oncologists should have, most of the oncologists should have that orientation towards the best supportive care in addition with the second line, third line, at least.
Okay. Thank you, Ravi. Dr. Aju or Chris, would you like to comment?
Yeah, I think this is where you cannot change oncologists. Chris knows very well that the amount of effort you have to put into disseminate. I'll give you a simple thought experiment. You gather 100 oncologists in India and ask them Chris Booth's name. Very few would say, but you ask them the best, the most fun oncology famous person's name. They would know because you go for conferences, you're talking about the fancy drug. It gets the most attention. Chris, sorry to
No, you're right. You're right. They may have heard of Aju Mathew because he's really smart, but they've never heard of Chris Booth.
The point is, a lot of this is still in the debate, in the academic books, in the journals. So my point always has been, we have to empower our patients. We got to tell them, you have to ask questions. You have to think. So the best thing to tell patients is, hey, ask questions. Simple question. What stage of disease do I have? Second question. If I use this drug that you say I should use versus not using it, how much more extra life will I get? So this one question is enough actually to bring the oncologist to reality. So empower patients.
Yeah.
Aju, thanks for that. Actually, I'm just going to share.
Even that question, sometimes if we say the particular drug called XYZ has 3 months survival, the most of the caregivers just fall into the trap. Let's have more than 3 months rather than not taking it. So even the survival benefit, and it also differs from person to person. We never know it's the median of survival or something that 3 months like that every patient will not have the same benefit. The side effects may sometimes take over than the benefits to some of the patients. So even that question sometimes makes like the 3 months is better. The patient I can see the patient, the family member can see the patient for 3 months. So the most of the caregivers does opt the fancy drugs based on that. Sometimes the situation is tricky. What I feel.
It is, Dr. Rabi, you're right. But the issue is oncologists overestimate, first of all, patient survival, but we also overestimate the benefits of our treatments. And I think patients and families massively overestimate the benefits. And so even if it's 3 months in a clinical trial, it's almost certainly less than that in the real world, maybe 6 weeks, 2 months, 4 weeks. And you're right, there can be exceptional responders, but these are aggregate numbers. And if we're talking about a sugar pill or a sip of water, then sure, we would do it for 4 extra weeks or 6 weeks. But as you well know, it's difficult because of the side effects, the financial toxicity, the time toxicity, all of these things. So I agree with Aju. I think we need to get to the patients and public. The palliative care community has been having these conversations for decades. They're much smarter than the oncologists, but we need this to get into the patient's hands while they're still making cancer treatment decisions. Aju just mentioned some questions. I'm just going to share a slide. This is something we wrote about in one of Canada's national newspapers on World Cancer Day last year. And these are five questions that I think every patient should ask their oncologist. And it's very much similar to what Aju just said. You know, what kind of cancer do I have and what is the stage? Is my cancer curable or not curable? Will treatment help me live longer? If so, will it add extra weeks, months, or years of life? What are the side effects of treatments, and are there other options? And how and where will I spend my time in the next 6 months? So I think, you know, empowering patients and the public and trying to change the narrative. The other problem, at least in the West, I don't know if this is the same in India, is this battle narrative, and I'm a fighter, I'm not going to give up. And so, you know, that fuels a lot of difficulties. And in fact, it also sets expectations very high. I was on a call with a patient advocacy group in the UK yesterday, and there is a very wise cancer nurse whose husband had just died of terminal cancer. And he had a very, very important comment near the end of his life where he said, it's bad enough that I'm dying of cancer, but I also need to die as a loser because I didn't win the battle. I mean, what a beautiful but sad way of summarizing what we've created of this battle narrative. And that's very much, I think, an American kind of way of seeing disease and model, but that's spread throughout many Western models of medicine.
So Chris, I usually ask my patients to talk about some of these questions to their oncologist, and usually they come up with nothing. They don't get answers, and even there might be first thing, they are afraid to speak to somebody who is not approachable, and second thing, even if they ask, they will not get answers for that. So those are some problems that I have seen.
Yeah, I think this is a problem across oncologists and all health systems. I think that there's some unique challenges in the Indian setup, and Aju, I'd like to hear his thoughts. I spent quite a bit of time in Kerala a number of years ago at RCC Trivandrum, so I'm not an Indian oncologist, but I consider myself an honorary Indian oncologist. And so my observations, as Dr. Sunil said, is there's a number of barriers to these conversations happening in Indian cancer centers. Number one is the huge clinical volumes of patients in the public sector. These are overwhelming numbers, and the patients and the doctors don't have very much time to have conversations. The conversations are very rushed. The second is that my understanding is that many of these concepts are not taught in training in medical schools across much of India or in residency programs, and perhaps the juniors do not see their seniors or mentors having these conversations. So they just might feel uncomfortable or might not know how to have these conversations. And then another kind of unique social cultural barrier is often the family doesn't want the patient to even know they have cancer or talk about expected survival. So these are complicated issues. I'd love to hear Aju's kind of reflections on what I just said and whether he has any ideas about how we can try to change that given the realities of, you know, the delivery of care in the Indian system.
So, Chris, I'm more optimistic about it moving ahead. The younger group of doctors who are getting out of training are more patient, are able to answer better. So I have an optimistic take on that. So I think you just have to, the challenge that I see from the side of the patients is right now, it's the lower middle class that's actually reeling under pressure. They have the pressure to go to the fanciest hospital. They have the pressure to go to the most famous doctor. The educated and the wealthier persons have the resource to find the right doctor to whom they can communicate, have the resource to go to make a decision as to how much they want to get this treated. And the information power differential is also balanced less. So, but as time goes by, I'm optimistic. One of the effort that currently I'm trying to do is to create a resource in my local language. So with a student, I'm translating a lot of the information in cancer portals using Google Translate. I realized just recently that Google Translate does a great job. Unlike in the past when it didn't make any sense when you put in English to Malayalam, now it does a great job So a lot of our patients are unable to read in English, especially the lower middle class and under. So if we can create a portal where they can actually find answers, I think the new age tools will also help. So I'm optimistic that things will be better. And like you said, palliative care actually has done the best part about going to the people directly. But Sunil will tell you that palliative care is now facing challenges because of that. Because they've gone to the public, I think there is a stigma about morphine. I think that is, I mean, I don't know, that is, I'm going to open it up to Sunil to answer. What do you think, Sunil?
Yeah. So I think it is not only the problem with the society, but uh, even there are healthcare professionals who actually ask the patients who prescribe this morphine. You should not take this, and they will have lot of explanations. So I think uh, the society already have an perception on when to take morphine and what is it, all those things. But I think it is as a healthcare practitioner, um, we should have the correct knowledge. So, um, but most of the healthcare practitioners doesn't have it. So that's also a problem.
Can I make an observation, Dr. Aju? I think you know me. I'm Dr. Biju, not Dr. Biju Raghavan, but Biju Gopi. You mistake the two names. Anyway, my observation here is that I worked with young oncologists like you and very senior oncologists also, without naming names, of course. The difference, what I have found is the older generation are more keen on going on with the treatment with newer modes of therapy and not giving up until very late in stage of when they give up to the palliative physician. But younger generation people like you are more amenable to the realities, and you are bolder in taking the decision of subjecting the patient to go for palliative care at an earlier stage, or at least involve us in a stage which is very effective and useful for the patients, so that the transition from the curative to the palliative will be very smooth. So this is my take on that, and that is exactly what I want to tell you. As a palliative physician, we are just like the oncosurgeons, because unless the oncologist refers the patient to us, we are not going to get the patients, because the primary, the care or the doctor, they are going to come to when the cancer is diagnosed or when there is a suspicion of cancer, is going to be the oncologist. And from there, the oncologist will be taking care of the curative part, because that's what is more important during the beginning of the disease, until the disease progresses to stage 3 and 4. That's when we may start coming in. But even the older generation doesn't give us that chance until the last few days or probably few weeks. So I think my take on this is that it's the oncologists, at least in our part of the world, where the people are not aware to whom to go to and whom to approach, who has to give the awareness to the people that palliative is what is good towards the end, or where you can ask them to incorporate it into their life, so that the transition will be very smooth. What I have seen is that when you are suddenly putting a patient who was in the ICU for probably 1 month, 2 months, or whatever, with various modes of therapy, with 5 or 6 consultants seeing them with a tube here and a tube there, and suddenly one fine morning the oncologist comes and says, okay, now you can go home because nothing for us to do. That actually devastates the people, that the patient as well as the people. It's not about the money alone. It's not even the time. It's the fact that, as you said, oh, it's lost. The whole thing is lost. So I have lost the battle. So they feel that they don't have time to, psych up their mind. Both the patient as well as the caregivers. They don't have the time to psych up their mind to say that, okay, we are going to face a reality where the person is going to lose a life. So I think we need to give them time. So that's where we can come in, because as again, Dr. Chris was saying, the patient load for the oncologist in our place is so huge. I've seen that an oncologist spends hardly 5 minutes with the patient, but I've seen an OPD where there are 150, 200 patients being seen in OPD. And the oncologist hardly has got 5 minutes. It's just like a GP clinic. So what can you tell the patients over there? Just he sees the charts and just writes the medicine. That's it. Go for chemo, go for radio, go for surgery, and that's how fast they are being churned out. So there's no time for conversation. But the conversation can happen with those patients if we are allowed in sufficiently early, where we can do that. The social part of it, the psychological part of it, or the spiritual part of it, and keep on supporting the patient with your care. That's what I'm doing right now with one of the oncologists with whom I'm working, who is a young guy like you. We go on very well together. So he incorporated me into his treatment, even in the ICU stages. Sometimes I go to the ICUs to see his patients. It's quite strange. I've never done that before, but it's challenging at the same time. It's very rewarding, because then we psych up the patient, we psych up the bystanders and their relatives. And as and when they transition into this post stage and end of life care or terminal care, it's very, very smooth and very rewarding, and they always accept it. And the result is very good.
Chris, how does this happen in your institution when let's say a new patient with stage 4 gastric cancer walks into your clinic?
Yes, sir, that's what I was saying. As I said, I work with 2 groups of people. One is the elderly group, who are very senior doctors. They call us very late, actually, very late. I mean, I've seen people who have come out with 3 colostomies which was not working, and they had fecal fistulas to, it's that kind of stage. So, but right now I'm working with a young group of oncologists who are quite bold in what they do, and they are very sure of what they're doing. Just like you, I'm like your age group. And so they know exactly what to say to the patients, and they psych up the patients. You see, this is it. I mean, there's nothing more for me to do. That's how they say. It's not that there's nothing for you, but they say that there's nothing more for me to do, so that we should give you the proper care rather than the cure. And that is how we are brought in. And usually I am brought in early enough nowadays for pain management, though they can manage the pain. Initially, they can manage the pain very well. I'm just giving morphine, but they won't. He just incorporates me into that, just to see that I'm there in the team, so that the patient also is familiar with me, and the caregivers are also familiar with me, and so the transition is more smooth and better accepted by the people. So that's a great relief for the patients, and it's a great reward for us also. Because see, unless you people say that, okay, palliative, this is what you need is more palliative treatment than curative treatment. If we go and say it, they will not accept it. That is what I have seen. So the assurance has to come from the oncologist. There's nothing more to be done.
Yeah, Aju, in my practice in Canada, and then we should get to Dr. Sairu, who has a question. So in Canada, it's pretty standard to have these conversations, but I think within the oncologists in Canada, there's a spectrum about how much detail people get into. So I think I tend to be on the spectrum of sharing a lot of information. So I've had, I've had 2 privileges that allow me to have these conversations. First, I've been taught how to do it, and I've had lots of role models. And second, in my morning clinic, I might have 12 or 15 patients, not 60. Okay, so I have the luxury of time for 1 or 2 of these conversations each morning. So if I meet someone with stage 4 gastric cancer in initial consultation, I'll go through the usual history and physical examination. I will summarize the case out loud, and then I'll say, is it okay with you if I talk about prognosis and timelines? And if the patient says, I'm also very clear in the consultation about whether the disease is curable or not. Okay, I tell them that. I don't ask for permission. I just say, look, I'm a chemotherapy doctor. You've come to see me. We're going to talk about treatments. I just need to be upfront with you, though. This disease is not curable. I have treatments that could help you, but I cannot make the cancer go away. And so I share that information upfront. And then I ask for permission for more discussion. I say, would you like to have a conversation about expected timelines and how long someone can live with this condition? First of all, if they're devastated emotionally, I don't even ask that question. I leave that for another visit. But if they're doing okay, I ask permission. Most patients and families will say yes, I'd like to have that conversation. Some of them say no, but the majority say yes. And then the way I frame it is I say exactly this. I say, I'm going to give you some numbers now. But before I do that, I want to tell you that oncologists are terrible at predicting how long someone is going to live with cancer. Studies have shown over and over again that we're very often wrong. So please don't go home and pull out a calendar and count any months or timelines, because we're often wrong. However, based on large studies of hundreds or thousands of patients with your condition, on average, patients live for months and not years. And this could range. Sometimes I've seen people live only 1 or 2 months, sometimes 4 or 5 months, sometimes 10, 15, or 18 months. I always like it when I'm wrong and people do better than that. But the general timeline now is months, and an average timeline would be in the range of 6 to 12 months. If we choose to do chemotherapy, it would involve treatment every couple of weeks. I list the side effects, and then I say chemotherapy on average can add a couple extra months of life to the numbers we've already talked about. So that's a pretty long, complicated discussion, but that's generally how I approach it in my practice. Dr. Saru has a question.
Thank you. Actually, it's not a question. Today, I really feel happy because I'm a person belonging to community medicine, and I have a long time association with the community, both with community-based palliative care and also in community-based education. So I really felt so happy hearing the thoughts that both of you, Dr. Christopher and Dr. Aju, echoed, because these were some of the real sentiments that were echoed in the community. But then we never knew the answers. We never knew, like the things that you said, whether the tumor growing one centimeter more, does it matter? I mean, so long as the patient, it does not matter to the patient. Actually, that is what I want to say. I want to express my happiness in hearing whatever was echoed from the community that I've heard, and it was reflected in your talks. So I'm so happy for that. Second thing I want to tell you is that I'm working in a medical college. So I feel that even now, the lens is heavily cure oriented. Because it is so cure oriented, these thoughts will not sink in somehow. That's what I have felt, being in belonging to public health. Everybody says public health is a priority, prevention is priority. But then when it comes to matters that cure oriented, even if it does not matter, that cure thing gets the priority over the other realms like preventive, promotive, palliative, and even rehabilitative. And I think you should give more conversations to the young group. Young group means the medical students. Okay, I wish my students heard both of you talk, because that is a new, that next generation, I think there will be a lot of change. And I mean, if using the new technologies like hashtag, something like that, if you could reach out to the medical students, the medicos all over the world, in echoing these sentiments, I think it would make a big difference. And another thing in medical colleges, even now, doctors do not like questions being asked by the patients. It somehow, I think it is perceived as it's not perceived well from the doctor side. That's what I understand. Maybe not all, I'm not generalizing, but it is a truth. And so patients also are not tuned to asking many questions. So I think everybody should hear what you told us, shared with us, this group. I wish the whole doctor community hears about it. And moreover, let us think about an innovative way to make sure that these thoughts are echoed, are sown into the minds of young medical students. I believe something really will come out of it. Thank you.
Thank you for those comments. And you're right. I mean, some of this work is being led by, the young whippersnippers like Dr. Aju and some of his colleagues, Dr. Bishal Gawali and others, who are very, very vocal advocates for these issues. And so I am hopeful that we'll change the next generation.
Dr. Chris, one thing what I wanted to express was that you said that, you are very forthright with your patients in talking about the timelines and things like that, if they are amenable to hear it. But in our place, we've got a cultural taboo that, it is never talked, even by the oncologist. Most of the time when we get into the palliative, what we are told is that my father does not know that, he has got cancer, so please don't tell him that. I mean, this is something which I hear every day. And then the caregivers say that, even the oncologist said, don't tell him. So we have this problem of cultural differences in trying to identify the disease and telling the patients, and it goes both ways. Sometimes the pollution happens in both ways. The patient says that not to tell the family, and the family says not to tell the patient. So both of them know that the patient has got cancer, but they don't discuss it. So this is something which we face almost on a daily basis, but we have to deal with it.
Yeah.
Dr. Palu?
Good evening, everybody. Sir, I had a small query. I couldn't understand much about regarding the low value care and versus the high value care. Whether it is like we can generalize this term or it is very individualistic. Like I said, Dr. Aju sir had given one example of bone metastasis, like one fraction versus single fraction versus 10 fractions. But I'm not able to understand in a broader way regarding these two terms. Could you please explain more regarding these terms, sir?
Chris, I'll let you answer.
Yeah, so I think, I mean, the value about the bone metastasis is that there's treatments that are going to be simpler and cheaper for patients and society. And for a number of reasons, entrenched practice patterns, I think at least in the US and perhaps in some elements in the Indian system, there's financial incentives to give more expensive and intensive treatment. And so I think that these decisions do need to be tailored to the individual, the patient, but there certainly are a number of things that we can do to deliver care that is just as effective, but is simpler and cheaper.
Parul, I'll give you another example from the gastric cancer and the breast cancer world. Now, both these cancers have a special marker called HER2, HER2 positivity. Now, in breast cancer, targeting the HER2 is very effective. In gastric cancer, targeting the HER2 is very less effective. So if I treat every single HER2 positive gastric cancer with an expensive therapy, that's low value care. But there may be a person who may get very good benefit. That's an exceptional person. Likewise, for breast cancer, this is a very valuable drug because we know from experience, from trials, that if you use that drug in breast cancer, the benefit, the magnitude of benefit is very large. So the cost of the drug remains the same. The magnitude of benefit differs. So if you look at value equals magnitude over cost, the cost is the same, but the magnitude changes, the value changes. So within one cancer world, two different diseases expressing the same targetable agent, same drug may have different value. So generally, yeah, so go ahead.
Individual to individual. We have to see as one patient to another patient. We cannot generalize this value care system, or we can.
Well, disease by disease, we can actually. For instance, the example that I talked about. But within that, of course, I cannot make a decision for a person saying a patient sitting in
I think probably his bandwidth is Dr. Aju, we are unable to hear you.
with gastric cancer, the magnitude of benefit is, oh, okay, sorry. So that is where I have to sit with the patient and then talk to the patient and explain to the patient, there is a medicine available if you have HER2 positive gastric cancer, but the benefit is not as big as the amount money that you spend. You tell me, do you have that sort of money to spend? Then sure, try it. But don't think that because the amount of money that you pay, you will get the same benefit. A lot of the medicines that you use are very expensive. So I tell all my patients who take those expensive medicine, just because you're paying 1 lakh rupees doesn't mean that you're going to get 5-star benefit. So I think that conversation is important.
Sir, understood, sir. Thank you so much. Thank you so much.
So for Matthew,
If my
sir,
patients are in doubt, I call Dr. Aju for second opinion to see what to do. So this is what really happens.
so for Matthew, sir, I would like to ask a patient of prostate cancer metastatic. Docetaxel we have given, and the second line abiraterone was also given. But after that, a third line enzalutamide, will we offer, or how would you take the call at that point of contact, because it's way more costly, and we are going for the third line for enzalutamide. Then how would you address issues at that point of time? Because in India,
So I do,
opposite to Kerala,
unfortunately, I do a wallet
as
biopsy.
opposed to Kerala, most of the other parts of the India, the patients and the caregivers are not much advanced or educated, what I say, or something. But it's still at the back step compared to Kerala. And most of the patients which we experience are the daily wages or from the low middle class, most of them, not from the higher group. So the questions being asked by the caregivers and also the patients were, they say, doctor sahab, aapko jo acha lagta hai, aap kar lo. That's the most of the things which they say. And of course, the corporate setups do take the advantage at some point of the time. But still, how would you address?
I do a wallet biopsy of the wallet to figure out if they have a sufficient insurance, to figure out if they have the resources. So this is where I mentioned in one of the talk, I probably did not talk about it. I like paternalistic style of medicine mixed in a wiser, prudent way. When I used to practice in the US, I used to tell every single points to the patient sitting in front of me because I couldn't care because they have insurance or Medicaid. Here, I don't even mention about things that I cannot, So if the setting that you talked about, that patient comes to me, I don't even talk about enzalutamide because if I talk about that, they're going to mortgage, they're going to pawn stuff and find money. So I don't talk about it.
Aju, I like that. We call that compassionate paternalism in oncology, something like that. You're right. It's almost emotional torture for the patient and family to even mention things they can't afford because they will immediately assume those treatments are more important than they are, and they will go to great lengths to get them, much to their detriment.
Dr. Kavin Kumar, you were waiting for a long time.
So one thing I want to say is I totally agree with Dr. Sairo Philip, ma'am. Being from public health background, so I must I really appreciate the efforts taken by Aju sir as well as both sir, like where the market is like whatever the medical market is. So we are going against it, but in the benefit of patients, that is actually good. And this my second point is like maybe if we can strengthen our health literacy efforts, to empower the communities, the cancer literacy or the prevention aspects of cancer care. So this might be these tools can be leveraged to make the people more empowered about the insurance schemes as well as the cost of treatment for various cancers. So thank you.
Great. Dr. Sunil, I'm
Chris?
going to need to run. I have another engagement I have to get to, but this has been a wonderful conversation. Clearly, it's an important topic that your fellows recognize and are going to be strong advocates for change in our system.
Chris, just one thing. You were talking about compassionate. I didn't get that. Compassionate?
Oh, compassionate paternalism.
Yeah, okay. Thank you for introducing.
It's interesting that Aju mentions that because in the old days in the West, medicine was very paternalistic, and then things shifted towards patient autonomy. And now it's almost we've gone too far, and we offer everything to the point where someone with, an 85-year-old with COPD and on dialysis might have a cardiac arrest, and we actually offer CPR, which is completely insane. And we shouldn't do that. And so I think, in the West, we kind of move back and forth between this, but compassionate paternalism would be, we are medical experts. We have insight into what is useful and what's not useful. And then the added complexity in Canada, where we have a public health system that pays for cancer medicines, I don't have the angst to do the wallet biopsy. I don't have to do that, but Aju does. And I think that's very appropriate because otherwise he's going to mention medicines that will cause financial ruin for families for 6 weeks of progression-free survival benefit on a CAT scan in Kochi. So I think that's a great idea. Anyhow, thanks very much,
Okay.
Sunil, everyone.
Thank you, Chris,
Okay,
for
bye.
that wonderful
Bye.
session. And are there any more questions which Dr. Aju can answer? I don't think we can go on like this, but maybe one more question if anybody want to ask.
My question to Dr. Aju is, how do you get like-minded oncologists to come forward and advocate more palliative care? It's so difficult from our side to do that, to make inroads into this aspect. It's like we are kind of being shut off until the last
So-
moment.
One way we have done is by organizing courses, online courses. So we've done 2 courses through Palim India for oncologists. So through those courses, 8-week long, 1 hour each, 2 hour each, 8-week long sessions, we've managed to create a cadre of oncologists who at least understands the philosophy. But my real challenge is as follows: going to my hospital management and saying, hey, I need palliative care physician. I am overwhelmed. My resources are met. My knowledge is banked. Can you help pay for salary of a palliative care doctor? That is my problem. And they will ask me, okay, how will we make money of that? So that is, it's a natural question. It's a very natural question, as hospital owners needs to figure out, management needs to figure out how they will pay for the salary, but they just look at the consulting fee and convert that into salary, but they don't see the big picture of patient retention or patient satisfaction. It is very difficult to communicate those things.
My answer to that, to the administrative side, is that what I can give the hospital, probably the other doctors cannot give. That is the goodwill and the prayers of the people and the patients. Because once that they accept the palliative care, and the situation right now for me, which is so humbling, is that when I was on the curative side for 40 years, people were sometimes thanking us for saving their lives. Now, after coming to palliative care, I just sometimes I have tears in my eyes when they say thank you for taking care of my father because he died peacefully. So that's so humbling. So that's why I said, I tell the the CEOs and the top guys, I said, so these are the comments which you get and the prayers you get. I don't think that money can buy that.
Sir, I wanted to add something regarding the health literacy thing you are doing. What you are doing, you are trying to translate into Malayalam. So many times I also feel that is one of the difficult things, even to tell what is palliative care. I need words to tell it in Tamil to my patients. I don't know how to tell palliative care in Tamil. We don't have a word for that.
We have a good word in Malayalam, and that's called palliative care. That has become it's become part of Malayalam language now.
That's because pallium is in Kerala.
Yeah. So even when I say Sandhura Paricharanam, people look at me like, what is that? And then I say palliative care. Okay.
I Googled it many times. I tried to use Google Translate also for palliative care, and it is showing something which is not acceptable. So even as Dr. Kavin Kumar and Sairu Madam told rightly, we need to have more of information, education, and communication activities to the people. When like you people have empowered us now, I think we should start empowering our patients. Health literacy will have a great role in it. And, this translation thing, if I'm having any challenges, I think I should reach out to you.
Okay. Thank you, Dr. Aju, for that wonderful session. I think all of the participants has internalized it, and yeah, and thank you. That was very active participation also. But we have to stop now.
Thank you for this
So-
opportunity. It's been a great experience seeing all of you.
Thank you,
Dr.
everybody. And
Aju.
it's our
Thank
to
you,
Sri Priya.
Thank you, Dr. Aju. Even being a non-medical, I also was like listening to many parts of your session very attentively. And just a humble suggestion to what Dr. Punitavati was saying, a concern. Instead of trying to like find out a translation, maybe we can convey through our actions that what we are doing. So without naming that, we can provide palliative care to them, to the needy, and they will understand that this is what is palliative care. This is what the different makes. Just a suggestion. So jokes apart, this is Sri Priya signing off for today. See you tomorrow with another interesting topic and yet another panel of eminent faculties. Take care. Bye-bye.